board. Hmm. All right, we are good to go.
Okay, we'll call the meeting of the Rural Regional Behavioral Health Policy Board for December 3rd. Call the meeting to order, and I'll turn to Valerie for a quick roll call just to confirm we have quorum.
Okay, Chair Fergus Loffridge,
Present.
Brooke O'Byrne,
Here.
Senator John Ellison, Dr. Erica Rist is excused. Robin Dunkhorst,
Present.
Wendy Nelson,
I'm present.
Chris McCann,
I'm here.
Patrick Rogers,
Present.
Sarah Dearborn,
I'm here.
the Honorable Judge Michael Montero,
Good morning. I'm here.
and Sheriff Jerry Allen. All right, with a couple of folks out, it looks like we do have a quorum.
Okay, I know Sheriff Allen had somewhat of a scheduling conflict today, so he might be able to join us as we go along here. I'd like to keep this initial meeting short, primarily for introductions of some new board members. But first, we'll open it up for public comment. And those online who wish to address the board, please limit your comments to 3 minutes, and action or items identified in public comment we cannot take action on today until they're properly agendized at a possible future meeting. Anyone wishing to make public comment?
For the record, this is Valerie Haskin. I would like to encourage anyone who is interested in making public comment to use the raise hand function on Zoom, or they can follow the directions to dial in by phone, which would be 408-638-0968 or 669-900-6833, and enter passcode 426234. Fergus, I'm seeing no interest in public comment.
Okay, let's move right along for the interest of time here and get folks back to their workday over the lunch hour. We'll go on to item 3, which is the approval of the meeting minutes from June 4th. We're still trying to get those located through the assistant that Valerie uses, so we will table that until the next meeting. Is that correct, Valerie?
Yes, please.
Okay, let's move right along to number 4 then. One of the most important topics today will be our new policy board members. And I'll open it to, we'll just go right down the list. Wendy Nielsen. Let me just back up. Folks, introduce yourself and what you're bringing to the table to be part of our policy board here. Wendy Nielsen, please.
Hi. So yes, I'm Wendy Nelson. And it's spelled weird, N-E-L-S-E-N, so that throws everyone off, just so you know. Yeah, so we are a coalition. We cover 4 counties. We do Pershing, Humboldt, Lander, and Mineral County. We are the only coalition in the state that is now a prevention and an action agency. And so we do a lot with food, housing. We have HUD housing for the first time out here in some of our areas. And a lot of prevention efforts. We do some harm reduction. So yeah, and I've been working with Valerie for years since the force, it started, and I'm thrilled to be a part of it. And so hopefully I can be beneficial in some way. So thank you so much.
Thank you, Wendy. Sheriff Allen, did you pop in here yet? Not seeing him.
And I don't know if you know, Sheriff Allen, we have a major wreck that shut down the freeway, and I think they've
Oh,
been
that's right.
handling that since 1 in the morning. Yeah, so that might
That's
be
right. He
why.
might be occupied with that one out there.
Yeah, nobody can
Sheriff
go.
Allen, I've worked with Sheriff Allen for a number of years on different initiatives. Uh, Sheriff Allen's uh, Pershing County sheriff, great guy, real advocate for community engagement. So we'll look forward to having an engaged law enforcement representative with us. Next, we'll go to Robin Dunkhorst, CEO of Humboldt General Hospital.
Hi, sorry, my camera is not working on Zoom today. I'm not sure why. I'll blame our IT department. Anyway, I'm Robin Dunkhorst. I'm the CEO here at Humboldt General, like Fergus said. I've worked with a handful of you fairly closely over the years, Fergus namely, and I bring to the table 28 years of healthcare experience, most of it in the emergency department as a nurse. Work very closely with Judge Montero on various projects involving mental health and drug court, as well as our behavioral health unit here and various suicide prevention initiatives in our county. I'm excited and I thank you for the opportunity to serve with you.
Thank you, Robin. Next, we'll go to the Honorable Michael Montero.
Hi. I say good morning because I'm coming to you from the north shore of Oahu, um, uh, and uh, and also I'm not in my natural habitat or my natural work attire, so please forgive me. But I'm Judge Michael Montero. This honorable stuff is hard for me to do, so you guys just Judge Montero's perfectly good. I should just let Chairman Loffridge just do my introduction. You did a really nice job for Sheriff Allen, so you could have probably done it for me. But I'm really excited to be a part of this group. I've worked with many of you. I think that those of you who are serving on this in this group are probably one of the reasons why when I was asked to apply, that was really the catalyst for me doing this is just to work with this group. I think will be wonderful and excited about that. And some of us go back a long ways. And I think one of my first introductions into this work of treatment, mental health was kind of in lockstep with Brooke O'Byrne. So it's good to see Brooke, and it'll be good to catch up. And as I think many of you know, I've been on the district court bench now for 17 years in Humboldt County. I think that my term on the bench has really been largely defined by work that I've done in the areas of addiction and mental health, and so this is exciting and a good time to probably get involved in this way. So I look forward to contributing. Thank you.
Terrific. Thank you. That's a great segue into, I would like our current board members to just give a brief introduction as to who you are and your representation here. And we'll go right after Judge Montero opened the door for me here. Brooke O'Byrne.
Sure. Thank you. Hi, everybody. I'm Brooke O'Byrne. Formerly lived in Winnemucca. I now live in Reno, but I work with a number of teams throughout rural Nevada who are implementing and coordinating behavioral health programs for residents. Um, and yeah, that's about it.
Brooke is very modest, but she always has good insights for us to keep us on track. So she's a good check and balance for me. We have a new legislative appointee, and that is Senator John Ellison, who is replacing Pete Gokachia. So we'll have hopefully him engaged with us as we go forward. Erica Riss, the psychologist based in Reno, but again, from the clinical standpoint, has much to bring to the table for us. Is excused today. That brings me to Chris McCann, Nelco.
Good afternoon, Chris McCann. I'm the EMS chief for Elko County. We run an ambulance service across all of Elko County, all 17,000 square miles, end up being our responsibility in one way or another. We work with some private and other public partners to do that. And I ended up on this board a couple of years ago as I was kind of advocating for mental health in our community and trying to address really the surge of mental health calls that we see related to drugs and just mental health problems in general. And so I'm happy to be here.
Thank you, Chris. Chris brings a wealth of knowledge for our rural EMS side of the representation on our board and how we can interact and connect those dots between healthcare and providers and EMS. Patrick Rogers next.
Good afternoon and good morning, Judge Montero. Would love to switch places with you at the moment. My name is Patrick Rogers, and I'm the clinical director of behavioral health for Nevada Health Centers. Nevada Health Centers operates, I've lost count, 20 to 21 health centers around the state, both in the rurals and in Las Vegas and Carson City, where I'm located. One of the things that I think I bring to the table is oftentimes primary care is kind of the portal to behavioral health for many of the patients that they're coming into health centers. And that's where a lot of mental health diagnoses and problems are being uncovered. And so it's nice to have behavioral health right on site and to be able to jump into action with those patients. And so within the rural area, I'll say the kind of the I-80 corridor there, we have sites that are in Elko, Carlin, Wendover, Jackpot. I think I'm missing maybe Austin as well. So, but anyway, so that's my story.
Great, thank you, Patrick. Lastly, Sarah Dearborn.
Hi there. Good afternoon, everyone. My name is Sarah Dearborn, and I am the chief over our medical, dental, and behavioral health benefits coverage for Nevada Medicaid. So I oversee all of the benefits we're building for our Medicaid beneficiaries as well as existing benefits too. So happy to be part of this group as always, and just really be collaborative and hear from all of your experiences out in the field and trying to make it make sense on paper for our providers as well, and also reimbursement wise too, because that's always important to keep it moving. So thank you.
Thank you, Sarah. As we close out 2024 and move in to 25, I'm excited as the chair to be able to work with this very diverse group, and I think we have some new members who are going to be active and engaged with us as we go forward, as we've struggled with that over the years, sometimes in the past. So I'm excited for what the future holds for us as we go forward, and welcome all of you. We have a number of folks that join our calls that occasionally will provide information and insight, also during the public comment or as a scheduled informational item, so that you as board members know what's going on. We've tailored that down a little bit for today as just being the inaugural meeting, and to kind of get us going and primed for the future ahead. So thank you and welcome. That leads us to item 5, which is the Rural Regional Behavioral Health Policy Board 2024 annual report. And I'll turn this over to Valerie.
Okay, thank you all. So please keep in mind that this report is again for 20 calendar year 2024. So it is not super recent. Um, the all of the regional behavioral health policy boards are required to submit an annual report to the Commission on Behavioral Health the year after of this end of the calendar year. One of the timeline issues that we kind of have is when the data sets that we use to support these annual reports come out. For example, the SEPTA regional epidemiological profile, which is kind of one of the major basis reports for this annual report. It says it was published in April of this last year. I wasn't able to get my hands on it until I believe June. And so it's kind of one of those things where that was also a time of transition between some other different programs. So I believe we are one of two of the five regional behavioral health policy boards that have completed an annual report for 2024. So just kind of keep that in mind. I do have approved December 2025 on here. That can be changed if this report is not approved during today's meeting. As we move forward, first of all, I would like to invite any of the board members to let me know if they had any obvious edits or changes or questions about the report that they would like to address before we kind of breeze through some things. Okay, not seeing anybody jumping up and down. Let's go ahead and keep it rolling. So we have just kind of basic regional description. Again, the listing of the 2024 board members as of a year ago. So you'll see some folks on here who are no longer members of the Regional Behavioral Health Policy Board. And the executive summary really kind of focused on the work this board did in preparation for the last legislative session at the beginning of this year. Also mentioned some continuing data collection and reporting issues. For example, the regional behavioral health policy boards, as per NRS 433, are required to, if available or feasible, report on data regarding mental health crisis holds, the outcome of mental health crisis holds and disposition of patient care, and a variety of other things. Unfortunately, that data is not available. At least not in a timely manner. So that data is frequently collected through various portals by the state and then analyzed, scrubbed for any inaccuracies and that sort of thing. But unfortunately, we do not have access to that information to report during board meetings or update on a platform. So that is something that my counterparts and I are working on with BPBH. Specifically with the Bureau of Behavioral Health and Wellness to identify how we can fix that. And that is named as a part of all of our scopes of work for this next fiscal year. So that's good news. Basic demographics of the region. Population density did go up a little bit from previous years. You'll see throughout the data section of this report, there were a lot of places where I tried to have kind of the last in reports information and this one side by side, just to kind of show any changes. When we get down to, all right. So veteran population, median household income, that I believe that did not change at all or not too much. It might have increased a little bit, but not a whole lot. Some points I did want to emphasize within the behavioral health specific information in 2023. So that's from the BRF, or I'm sorry, the Youth Risk Behavioral Survey. 44.3% of high school students and 35.4% of middle school students residing in the rural region reported feeling sad or hopeless. And that's kind of their entry level data mark on this specific piece regarding mental health for young people. And then we have seen that's a little bit of a decrease from the last Youth Behavioral Risk Survey. So in 2021, the last time that was done, it was 45.8% of high school students and 34.9% of middle school students. So that's good news that we're seeing some decreases there. I don't know if that's a statistically significant change, but at least we are seeing a little bit of a trend downward. And then also when we go down to um, considering suicide, we see 23% of high school students and 23.7% of middle school students had considered suicide. That is an increase. So in 2021, it was 21.7% of high school students, and then 20.7% of middle school students. So while there may be fewer kids who are feeling sad or hopeless, that might be a little bit more acute. Coming down here, the next point, 21.4% of high school students and 15% of middle school students residing in the region have reported planning to die by suicide. That does not indicate an attempt. It just indicates having a plan. That is pretty similar to the last youth risk behavioral survey. So that's 21.7% of high school students and 13.9% of middle school students. So it was a little bit of an increase amongst middle school students. And then when we talk about attempts, we've got 10.7% of high school students and 9% of middle school students in 2023. In 2021, that was 12.1% of high school students and 8.1% of middle school students. So a little decrease on the high school side and a little increase on the middle school side. There was significant decreases in emergency department encounters amongst rural residents between 2018 and 2021 for behavioral health related diagnoses. It should be noted that there were a lot of fluctuations, and particularly obviously through 2020 and 2019. Inpatient admissions for anxiety and depression remain higher than inpatient admissions related to other mental illnesses. Again, there's a lot of fluctuation. When we come down here to this figure, we're looking at specifically depression diagnoses over a 9-year time period amongst rural region residents. So this is again that our 6-county region. And here in orange is the residents specifically of the rural region, whereas blue is Nevada as a whole. So a lot of fluctuations. There could be many different reasons for a lot of these fluctuations. It could be whether or not physicians or doctors are screening, if questions are being asked, what services might be available. It's difficult to say why there could be fluctuations, but just so that you are aware. And this next graph looks at use of overdose as a mean of attempt to die by suicide. We are seeing some decreases in that, so that is good news. It should be noted that really amongst deaths by suicide, 73% were completed utilizing a firearm as lethal means, which is pretty consistent across the board for not just the rural region, but other places as well. Generally speaking, the more lethal the means, the higher percentage that means has in contributing to deaths by suicide. Other things when we're looking at here, so percent of adults reporting excessive alcohol use by county, we actually saw decreases across the board in different county level screenings, so that's good news. When we look here, this is suspected drug overdoses. This is from the dose reports through OD2A, I believe. And so we're seeing kind of decreases in those suspected overdoses. There are always going to be spikes, probably in spring and also in fall with the seasonal changes. Self-reported substance use by high school students, where we're getting to those combined counties. So this is also done to the Youth Behavioral Survey. They did combine counties just because the sample sizes are pretty small. So it also helps kind of de-identify some of the information. So we have the Tri-County area of Elko, Eureka, and White Pine counties. Generally decreases in most things except for vaping products, which is probably not a surprise to anyone who works with youth, and also a smaller increase, but still an increase in marijuana use. Same trend really with Humboldt-Lander Pershing. However, looks like not the same increase on marijuana. But when we look at the vaping product increase in use between 2023 and 2000 or and 2021, it's pretty large. So that can be quite alarming. We know that when kids get their hands on those, it's always not always just tobacco products that are being utilized in there. So that can be problematic. Behavioral health workforce across the board, the takeaway point here was that the behavioral health workforce by and large is improving in the rural region. That being said, we still have a lot of work to be done. So while we may see increases from, 3 psychiatric APRNs in 2022 to 25 in 2024, is that necessarily enough? Is it not? And this is also by county level. So seeing some really great progress with psychiatric APRNs, some pretty decent increases in alcohol, drug, and gambling counselors, although it's for the most part, the numbers are pretty stable. We did lose one in White Pine County, it looks like. Some changes in the numbers of marriage and family therapists, and then increases or stabilized numbers in the number of licensed clinical professional counselors. When we're talking about the different types of providers, one of the things that I learned through going through the behavioral health provider crosswalk process and identifying what the different educational requirements are and the different scopes of practice. When we're talking about specifically crisis response, while any master's level provider is able to provide those services, sometimes our licensed clinical professional or licensed clinical social workers, so LCSWs, and licensed clinical professional counselors may be a little bit more oriented towards some of that. Licensed marriage and family therapists are, of course, also able to provide those services. Their specialization is really looking at the health of the individual within the context of relationships and families. So kind of different orientations to each of these different provider types. But at this point, any of those masters or even doctoral level providers can definitely do that type of work. Um, you know, no psychiatrists located in the rural region still, unfortunately. And we had an extra licensed psychologist added. There's, as per 2024, there was one in Elko County and one in Humboldt County, whereas in 2022, there was just the one in Elko County. And also increases in the number of licensed clinical social workers. So insurance coverage has increased a little bit. Medicaid enrollment had also increased a little bit by county. So I don't necessarily have the cross comparison of the increases of insurance coverage amongst all persons in the county. How many of those were private payer or private coverage, and then how much of those are public. But it does look like the public coverage might be a major contributing factor to that. And then things that have continued over. So continued difficulty finding placement for patients needing crisis stabilization or inpatient care in a timely manner. Transportation to both crisis and outpatient services continues to be a challenge. There's hopefully some things coming around the corner in 2026, but we'll see what happens there. Lack of mid-level services is another chronic issue. So statewide, not just in the regions that we work with, there's some crisis stabilization, and then there's outpatient, and generally large gaps of all those services in between. And so particularly for people who may be covered by fee-for-service Medicaid, the MCO coverage is rolling out January 2026. So fingers crossed that will help provide additional access to some of those private intensive outpatient programs and other mid-level services for folks who previously weren't able to access them through fee-for-service Medicaid. And so that's kind of a lot of the issues relating to behavioral health and a snapshot there. Any questions about the data from members of the board? Okay. I talked a lot about your work, developing your bill for this last legislative session and everything that went into that. The following section is talking about your board meetings and presentations. We had a fair number of board meetings in 2024, so that was great. We definitely met the at least once a quarter requirement. And that is pretty much it. The rest is references and appendices. Any questions, edits, comments from the board?
No, it looks great, Brooke. It looks great. And I second what you've got going on there. We're seeing exactly like, especially with the vaping and things in the schools, we're seeing a lot of that. So Valerie, that aligns with exactly what our principals are reporting. And so it's great information. Thank you.
Thanks, Wendy. And Patrick, I see your hand is up.
Yeah, for the record, Patrick Rogers. A couple of real quick comments. I want to, as far as the data and the screening, I guess I would endorse that. We're seeing that, especially at a primary care level, we're not doing a very good job at screening patients coming in for behavioral health and mental health areas. And I say that from firsthand experience because I work in primary care. While we try to do the best that we can, we do know that that is an issue. The other thing when we're talking about workforce and the access to behavioral health, I think that there's going to be some question. And Sarah, I'm not going to put you on the spot. You don't have to comment if you don't feel ready to comment on it. But I know that we're seeing the expiration of telehealth happening. And I'm wondering if there's any comment on that, any discussion about that's happening and how it's going to affect the rurals.
I can definitely speak to that from the Medicaid perspective. So I know there's been a lot of federal guidance around telehealth expiration, but luckily states have the ability to make their own telehealth policies for Medicaid. And so our telehealth policy is rather expansive. For Nevada, it has traditionally been, and then I want to say it was in 2021 where SB 119 was passed, that really emphasized the need for telehealth, whether it be audiovisual connection or audio only for behavioral health services. So Medicaid had revised our policy based on that legislative guidance and really emphasized the need for telehealth service delivery to be clinically appropriate and medically necessary for the individual specifically. So from a Medicaid perspective, we're still pretty expansive and flexible with that, but really leaning on the clinical expertise of the providers and ensuring it's obviously individual's choice as well.
Thank you, Ann. I appreciate that, Sarah. Appreciate it.
So Sarah and Patrick, would there be potentially opportunities to identify statutory changes for this next legislative session to help support telehealth use, or is that kind of all a done deal to the extent that we can without interstate licensure compacts or anything along those lines?
I think I think it was 2021. I'll have to double check, but I really do think that Senate Bill 119 really helped kind of solidify for Medicaid at least to be able to make our own rules and not necessarily follow the federal government's. Even when I've had work on some state plan amendments and talked about telehealth with CMS, they continue to emphasize like their goal is to kind of stay out of that and really leave it up to states. So, but I'd leave it up to others to understand if that might need to be supported. You all are seeing it kind of on the ground floor, so.
Yeah, I would agree. I'm not sure if if we would need more legislation around that if we're not predicting a lot of changes. I know the Medicare side of things is kind of where the real issue is. And so, but thank you, Sarah, because sometimes we don't always know what's the state going to follow and whatnot. And with the expansion of MCOs in the rurals as well, what the decisions will be there. But I don't know if it would need any kind of legislative stuff. So.
Chair Lawfridge, there is a non-board member with their hand raised to contribute. Would you like to take that comment?
I'll just real quick before we do that, I just want to touch on Patrick's comments there, and the question that you asked, Valerie. I think this would be good to keep on our vision, our radar, as we prepare going into session in a couple of years, is that to see what the impact of the managed care organization, Medicare, will have in this realm of telemedicine. So let's keep that as a possibility.
Will do.
Okay. Fran, you had a comment, brief, if you could, please. You're muted, I believe. You're still muted, Fran.
Okay, how about now? Can you hear me
Now
now?
you're there.
Okay, hi everyone. This is Fran Maldonado. Real brief. I am with the Department of Public and Behavioral Health, Bureau of Behavioral Health, Wellness, and Prevention. I oversee the certifications, excuse me, the behavioral health certifications for excellence in Nevada. So we provide certifications to providers throughout the state in substance use, and we'll be adding mental health services as well. I just wanted to chime in on the telehealth. We had a strategic plan that was just recently published, and one of the main identifying needs across the state, of course, no surprise to everyone, is access to care. So here at the Bureau, we are updating or in the process of updating our regulations and our division criteria to allow for certification of telehealth providers. So I just wanted to throw that out there. So hopefully that will help out with the need.
Appreciate that. Thank you. Thank you for the insight.
Mhm.
Other board member comments as we move along? This is an item for action. If you, as board members, like this format, like the information, granted, this is from 2024 to finalize now, way at the end of 25, but that's the way the data works. If you like this, so that we can finalize it, I would entertain a motion to do that.
This is Brooke O'Byrne for the record. I move that we approve the report as it's written. And I also want to say thank you to Valerie for putting it together. It's a lot of work.
Valerie always does an excellent job.
This,
Go ahead, Wendy.
I second the motion.
You may.
Yeah, this is
I had you there, Wendy. You clicked off to mute.
You're good.
Got you now.
Yeah, I second the motion.
Okay. All right. Any question? I'll call for the vote, and because we have such a large group, we'll have any that do not support the motion and the second. Hearing none, it'll pass by unanimous. Okay. All right. We'll move that one along. Thank you. Great work, Valerie, as always. It's tough dealing with the data sources getting to you in a timely manner. Let's keep this moving. We're 20 minutes before the hour, so I want to just keep moving right along. Item 6, Valerie, I'm going to let you lead this off because you had the initial conversation with a concurrent meeting of the 5 regional behavioral health policy boards scheduled for next week.
Yes. Let me see here. All right, so with the concurrent Behavioral Health Policy Board meeting next week, so just how this is going to work is it's essentially all 5 boards are having a meeting at the same time with the same login information. And so the different chairs will take turns calling roll for their respective boards. If a board does not make quorum, that board is technically not meeting. However, because login information is the same for all of the boards and all of the meetings, um, anyone who is a member of a board can stay on and listen to the presentation, just won't be able to participate as an active board member. I believe that there's going to be 2 major presentations, one from the newly created Nevada Health Authority, and then one actually from the Bureau of Behavioral Health, Wellness, and Prevention within DPBH, about the strategic plan, and what that may look like for all of the different boards. So we're trying this as a strategy to get information out to all 5 boards in a timely manner, so that each of, the presentations, people aren't working to try to do the same presentation with different boards, which oftentimes takes several months, if not an entire year. So this will kind of streamline that process, and then also provide an opportunity for members from all of the boards to make comments and kind of hear each other's perspectives across the different boards, not just within the single board itself. So we're hoping that this will kind of also be a strategy to increase collaboration across the different boards. So any questions about that?
Encourage our board members to make the time to be available for that on Monday, December 8th at 3 p.m.
I can't on my iPad, can't figure out how to raise my hand right now, so I apologize. I'm just going to ask. This is Mike Montero for the record. Valerie, I have court on Mondays, all of most of my specialty courts. I'm probably going to be available for about an hour. Is that going to be sufficient? I don't want to affect the quorum issue, but I might be able to join for just that first part of the meeting.
That should be fine. And there's no voting items on the meeting, so I'll keep an eye on it. And if quorum is broken, then we will call the close of the rural board meeting. But that, because another board will still have quorum, the meeting itself and the presentations will still go forward.
Okay, thank you.
Yeah, so we should be fine though.
Other questions? Okay. We will close that one out and move to item 7. Valerie, if you can provide us a quick overview of what happened following legislative session. This is our first time to get together since then, and really where we're at with that, help engage going forward.
All right, thank you. Again, for the record, Valerie Haskin, Rural Regional Behavioral Health Coordinator. Can everybody see the presentation itself, the presentation slides? All right, I'm seeing nods. We should be good to go. Okay, so first I'm going to start with the bills that did and did not pass from the legislative session itself. I've taken this information largely from another legislative recap that I did with my counterparts for the Behavioral Health Association of Nevada earlier this year. Workforce development, there was of course a topic of conversation here. We saw the passage of AB 60, which was the bill from the Northern Regional Behavioral Health Policy Board, and that was the codification of certified prevention specialists, which are largely kind of designed to be seated within the prevention coalitions and help provide some professionalism and guidelines for work done in prevention. As you are all likely aware, one of the issues that we have culturally with prevention is that there's a lot of things that may not necessarily be evidence-based that people still like to lean on because it makes us feel good, but it may not actually work. And so the hope is that by really kind of moving forward with certified prevention specialists, we'll see more evidence-based practices implemented for prevention and a little bit better regard given to a lot of those higher quality prevention efforts that we see, particularly from our prevention coalitions and similar nonprofits. We did see the passage of the Counseling Compact. This was Assemblyman Hafen's bill, AB 163. We were very excited to see that. Very disappointed that SB 68, which was your bill, did not pass. We never got that to see the light of day, but at least one of the compact bills did get passed. Same thing with the multiple healthcare focused interstate licensure compact bill from the Patient Protection Commission. That's SB 34. That also never saw the light of day. We also saw the creation of a new type of behavioral health provider, which would be from SB 165, the behavioral health and wellness provider. This is meant to be kind of an entry level for people who have like a bachelor's level degree in psychology and who are interested in working with specifically youth is what the way it's designed at the moment, and would be working under the supervision of master's level licensed providers or school psychologists. And so the idea is that if there is an organization like the Boys and Girls Club or a school who needs additional hands to help work with children under their care and under their treatment, we would have these additional providers with at least bachelor's level experience who could work with the school psychologist, school social worker, or a licensed clinical professional counselor, licensed social worker, et cetera, to help work with these kids in a non-clinical context and would work in conjunction. So it wouldn't necessarily be a standalone provider working on their own. This is based off of a model out of Oregon. We did see a couple of other compacts that didn't pass, like SB 227, which was the school counselor compact. And there was another bill, SB 495, which would have created the Office of Mental Health within DHS and the Nevada Health Authority, and would really kind of create other additional requirements for training for licensed psychologists under the Board of Psychological Examiners. Focusing more on children and youth. So we saw the passage of AB 6, which was the creation of a program to address fetal alcohol spectrum disorder within ADSD. We also saw AB 1518, which is an interstate compact for the placement of children under foster care to help place them in a more safe or appropriate place if there's none available within Nevada. There were some other bills like SB 306 and SB 314. SB 314 really looked at reforming the requirements for mental health education in schools. A lot of times these things just didn't have enough traction, and there was a little bit too much of a fiscal note that might have been attached to them that was really more than what was palatable at the time for a lot of our legislators, particularly not knowing the landscape of federal funding that might or might not be coming in. Crisis response, we saw the passage of AB 380, which changed the effect, the makeup and where different crisis response teams could be housed. Previously, crisis response teams had to be housed within essentially a behavioral health agency. However, now with the passage of this bill, that also opens that up specifically to law enforcement. So, for example, right now or before the passage of this bill, if there was a MOS team, the program itself would be housed under the agency that may house the behavioral health provider separately. Whereas now with the passage of this bill, you can have a MOS team that is within a sheriff's office or a police department and is fully within just that department as well. And they can also employ the clinician separately within their own house. So that kind of opens things up a little bit. I believe it also opened up language for crisis response teams to be housed within EMS and fire and be reimbursable by Medicaid. So that gives us some more options. Access to lethal means was a topic that came up with some interesting bills. AB 181 from Assemblywoman Gallant was really kind of best aligned more with best practices that we've seen from other states that would remove liability for persons who wanted to maybe temporarily surrender their firearm to a club or a family member or somebody else for safekeeping if they felt like they could having access to that firearm could be a danger to themselves or others. That bill never saw the light of day. However, we did see the passage of AB 451, which creates that limited liability for safe storage, I believe, within retailers of firearms and then also for law enforcement. So we'll see if that actually gets used or not. I'd like to think that hopefully it will be. SB 347 focused more on people who have been under mental health crisis holds and their current and future access to firearms. The first iteration was a little problematic for communities that are in our region where you see a lot more of gun culture, right? Because it was really stigmatizing towards the connection between mental health and firearms. While my conversations with a lot of law enforcement leaders, nobody wants to see someone who could hurt themselves or others necessarily with a firearm in their hand. The way our legal system is set up is you are innocent until proven guilty in a court of law. And the concern here was that if people thought they would have their firearms taken away permanently if they were placed on a mental health crisis hold, that would be incredibly stigmatizing and may prevent people from reaching out for help when they need it. So the version of this bill that was passed, luckily, gives any law enforcement officer who is responding to a mental health crisis hold the ability, not the mandate, but the ability to confiscate a firearm that is within that individual's immediate area. So if they're in a car, if it's on the bench, anything that is within their grasp, they can confiscate that. And they have to give the person a receipt once the person has been cleared from their crisis hold and or inpatient depending on the situation, they can take the receipt back to the law enforcement agency and retrieve their firearm. So a lot more friendly for our communities who really hold gun culture in higher regard. So definitely a little bit happier about how that bill went down. Opioids, so we had AB 19, which changed the membership of Surge a little bit. AB 394 created a mandated that the Nevada system of higher education creates an emergency response plan that also includes opioid overdoses. This is a concept that you guys heard before the legislative session and before you had fully completed your BDR as a possible concept. So glad to hear that this did pass. SB 231 created new requirements for safe and secure drug take-back efforts just to make sure that the way that the drug take-back boxes are managed also kind of helps decrease the ability of people to break into them, decreases vandalism and those sorts of things. There was a non-opioid directive bill, SB 337, that did not pass that would have enabled people to essentially do an advance directive in case they were injured and were not able to speak for themselves. So that if they did not want to have opioids, they wouldn't be given opioids if they were unable to speak on their own behalf. And then, of course, the governor's public safety bill did not pass during session. That does have some opioid components, and we will be talking about that in a minute. AB 433 saw the creation of the Purple Ribbon Task Force, which was the purpose of that is to identify ways to better support first responders, specifically law enforcement and fire, named there within that bill regarding their overall wellness and mental health. Lots of bills regarding insurance and Medicaid, while the Washoe Board's bill, SB 47, did not pass regarding payer parity. AB 207, which did very similar things, did pass. And what that essentially does is mandates that the private insurance companies need to improve their data reporting to the commissioner on insurance so that they can identify where the actual hangups are regarding payer parity, so that we have a better understanding of the landscape and what the hangups may be for future legislative session. Bill I'm very excited about, AB 514, that creates rehabilitative residential mental health care facilities. And so that's going to be like a step up from like a group environment for mental health. So that's a little bit more of that mid-level care that we've seen be really problematic. SB 300 codifies coverage for services of some providers, including, I believe, APRNs and psychologists at FQHCs. SB 353 allows coverage of Medicaid to cover training expenses for like clinical internships. Other system changes. So we saw the passage of SB 494, which was the creation of the Nevada Health Authority. That has, to be honest, I was a little nervous about that, but seeing how the Nevada Health Authority moved forward with its application process and developing its application for the Rural Health Transformation Grant really was very heartening. I'm pretty excited about the work that they're doing. A lot of these other bills mentioned here really focused on changing the structure of statutory boards, sometimes including the regional behavioral health policy boards, and also combining occupational licensing boards, such as those that oversee behavioral health providers. None of those passed, so there's not any current revisions there. So let's talk a little bit about the special session. There was only a couple bills that really touched behavioral health. We had the governor's crime bill, AB4. The main behavioral health components there, it does require any sort of detention or jail or correctional facility that decides to implement a program that addresses opioid use disorder to coordinate with DHS, which makes sense because they have a lot of funding specifically for opioid use disorder. So it's just kind of requiring the two ends of the same piece of string to meet. And then the other one being increased penalty for DUI accidents resulting in death. SB 5, which was the statewide healthcare access and recruitment program. So this is really focused on workforce development. It was a huge appropriation of $60 million to create this account that will be overseen by the Nevada Health Authority. And this will fund sustainable projects to increase provider levels across Nevada. But they have to be specifically focused on provider shortage areas, different types of providers who may be within those shortage areas, and there is a match requirement. So reading through this, I immediately thought, Be Here Nevada would probably be a good candidate for some of these funds. And also because it does have to be sustainable longer term projects. There was also some provisions there focused on occupational licensing for physicians and DOs. Please note that with those two occupational licensing boards, they do cover psychiatrists as well. And that is it for the legislative recap. Does anybody have any questions?
Okay, no questions. Thank you for the recap. Obviously, very interesting time with the unknown budget impacts that were coming from a federal government while session was in process and shortly thereafter. So a lot of things happening. And it's good to see that behavioral health is continually getting more and more traction in the legislature and actually being addressed in some initiatives. Valerie, can you give us we're coming to the top of the hour here, quick update on your activities and work that you have forthcoming?
All right, so I actually just got my updated scopes of work from both of the grants that I work under in the last couple days. So that should be good to go. We've got some really great stuff coming up, continuing forward with a lot of different projects. Some of the things that we also have that I've done since the last time we were able to finally meet is we did an MCO rollout webinar that had really good attendance. The behavioral health provider crosswalk is done. I just need to make a couple tweaks and then send it on out. I'm working on a postvention toolkit project with some of our stakeholders based out of Elko. For those of you who aren't familiar with the term postvention is a set of activities or strategies that can be implemented by companies or organizations or even communities after the loss of someone to suicide or even overdose, depending on the situation. And so having policies and procedures in place and tools in place before the worst happens can really help a lot of people through navigate those types of situations that we really don't want to have to be in the first place. Unfortunately, a lot of tools that are available are really focused on either within the context of schools, which is great, but there's more community organizations that can be touched by postvention or can be touched by suicide than just schools. And they're also usually focused more towards urban environments. So working with some of the stakeholders out there on that. Also working on identifying some training options for clinicians who may be a part of behavioral health crisis response. So for example, many people may not be aware that through their course of training, behavioral health clinicians, even master's and doctoral level providers, may not have any robust crisis response training other than somebody says suicide, put them on a mental health crisis hold and call law enforcement so you can go to a crisis center because it's oftentimes seen as too much of a liability. So that being said, there's a couple different training options, one out of Michigan and one out of Virginia, each with different focuses. One's more on like the academic side and kind of that sole clinician and or peer model, whereas one is focused on clinicians who are co-responding with law enforcement and how to help keep them safe and also keep their co-responding partners safe. So working on getting some webinars from those teams up and running. They did present at CIT International. I'm also working with NAMI Northeastern Nevada on, or NAMI Western Nevada on some CIT projects regarding standardization and figuring out how to resuscitate the CIT Nevada website. There is currently a Project Echo out of the Office of Statewide Initiatives that they are planning. It's going to be a series for crisis response, specifically geared towards law enforcement and first responders. So how to navigate crisis response with, specifically, they're going to focus these early sessions on crisis response with children and people with intellectual and developmental disabilities, but then expand from there as need arises. So as that information is done, we'll get that out to you guys. I'm on Tina Gerber Wynn's group for kind of identifying what jail community reentry programs are already available in Nevada, particularly rural Nevada, and what kind of needs to be going on there. So that's really great to see that collaboration going on there. I've also going to be working with Bill Teal on some sequential intercept mapping processes for this next fiscal year. And as you are all probably aware, with the next deadline for your bill draft request submission being September 1st of 2026, we will be spending a lot of our meeting time in the next few months really looking to identify a topic for your bill draft request and what types of language needs to be changed. So board members, if you have any specific topics, anything that's happening in statute that is problematic in order to, in keeping people from connecting to care, that's the kind of stuff we want to look at changing. And then for quality, still having issues with people with complex issues and trying to find appropriate care for them in state. It's kind of horrifying how frequently people are frequently having to go out of state. And then there was another interesting topic that came up that I want to put on your radar was organizations that don't necessarily provide clinical care or treatment and they're private pay only. But where's the line where they may be crossing over into providing services without a license? So, for example, someone who maybe is a life coach, if they're providing supportive services, where's that boundary? And then if that person is acting unethically, who's the reporting or overseeing body? So there's some questions that have come up regarding some of those practices amongst organizations in the region that we all serve. And so I just want to put that on your radar as something that may come up, because if they're private pay only, then they aren't beholden to Medicaid. If they aren't a licensed provider, then they aren't overseen and can't be punished by an occupational licensing board. Where's the line between coaching and clinical practice? So those are some of the things I've got going on right now. Any questions from the board members?
Hearing none. Hearing none. It's good stuff. You have a lot going on. Just before we get into the public comment and close this out, we have not scheduled, or do we have scheduled our next meeting other than the concurrent meeting with the other boards?
Not yet. So as we have several new board members, I was going to reach out to board members individually and see if we can identify some times to talk about. Currently, we're meeting on the first Wednesday of the month at noon. every other month was the schedule. Do we want to move forward with that? So I'll be contacting each of the board members individually to see if that still works or if we need to change it at all. And then I will take that information, de-identify it, and I'll work with you, Fergus, to at least identify a next meeting date where we can propose a schedule for 2026.
Perfect. That was the answer that I was looking for. All right, let's move this along. I try to keep these short, informational for you so we don't take up a lot of your time. Next, we're going to go to the public comment. Again, open this up. I already see hands raising. 3 minutes. And again, these will be just items that we can consider, but no action will be taken today. And Molly, go ahead.
Hi, folks. Sorry I missed the very beginning and the first one. Molly Rose Lewis with Senator Jackie Rosen's office. I'm the healthcare point person for all of Northern Nevada, including this whole region. I just wanted to say hello and mention a couple of things that I heard during the meeting that I wanted to follow up on briefly with the telehealth. I think if we're not clear on that, I know I was a little unclear too on where we are. The Medicare telehealth allowance needs to be redone with the new CR. So at the continuing resolution with our current budget will run out again at the end of January. So we'll be looking at hopefully that going through again then for that timeline. And Senator Rosen is very concerned about that. And it's something that is on our team's radar for sure. So just mentioning that if you have questions or want to follow up on that, I'm happy to do that. I do have one kind of cool piece of news that Senator Rosen is introducing a bill, I believe today, that is creating a pathway for companies to register as nonprofits in order to then be able to develop drugs and medical devices. Up until now, that's not really what nonprofits have been used for, so it's been difficult for people to get that nonprofit status. So it's kind of an interesting, innovative way of getting some more research and innovation and products and affordability for products in the country. So if anyone has questions or wants to follow up with me on things on the federal level, please reach out anytime. Thank you so much.
Thank you, Molly. It's nice to have the insight of what's going on at Capitol Hill. Appreciate that. Other public comment? Hearing none, going once, twice. Okay. We will call this meeting adjourned at 1:09. Sorry, we kept you a little long there. Lots of information. So we will adjourn, and Valerie will be sending out surveys to the board members for the upcoming meetings. Remember our December 8th meeting at 3 p.m. and that notice has already gone out and that agenda has gone out to all the board members. So be there. We'll see you then. Thank you, everybody, and welcome to our new board members. We are adjourned.
Thank you.